Hey, future respiratory therapist, as you get ready to go back to school this next week, or maybe you already started back this week, or maybe you have another 2 weeks off, whenever it is, many of you are probably going to be diving into a disease course this semester. And others of you may have already taken your disease course. So what I want to do is give you a little bit of insight here on a method that I encourage my students to instill to study diseases. Because if you try to remember every bullet point along the way, you're going to get lost and you're going to confuse things when it comes down to taking your exams and treating your patients. And so I want to show you this technique. And basically it comes around this. Now we spend lots of time in the car listening to the radio. So the first thing you got to do is stop consuming data, information, entertainment, and start utilizing that time to shore up your knowledge base on some of these disease processes. Now you can do this with just about everything in respiratory therapy. Okay, I'm going to do it this week with a few different disease processes. Put in the comments below what you want to see, and I'll do the exact same thing with that disease process at a later time, okay, coming up this week and into next week. But I made this post on Instagram, and I wanted to put it out there to go a little bit further in depth in this. So today we're talking about pleural effusion, okay? Now what I recommend you to do is to break down each disease process into about 4 or 5 bullet points, simple bullet points that really drive home some key terms that you need to understand with that disease process. Okay, so here's how that would look. Pleural effusion. The first thing you need to know is that we're talking about fluid. Now that's all the first bullet point says is fluid. And then on your part, what you need to understand is that that's fluid where? In the pleural space. Okay, now the second bullet point is exudative versus transudative, which is going to define the source of that fluid or what type of fluid it is. Okay, now this is important because this is going to link back to the cause of the pleural effusion. So in your mind, your bullet point is only exudative versus transudative. But while you're driving, you expand on this. You say 1, fluid in the pleural space. 2, exudative or transudative. This tells me what type of fluid it is. Exudative relates back to disease processes of infection or inflammation, such as lung cancer or pneumonia. And then you say transudative. If it's not exudative, then it's transudative. Transudative, the word trans meaning across. So you just have the movement of fluid into the pleural space, not associated with a disease process. So when you say not associated with an infectious disease process. So when you say transudative, you should think of things like congestive heart failure. Okay? And then third, you have your key radiological findings. So blunted claustrophrenic angles is, take it to the bank, your key finding for a pleural effusion. And then to further diagnose your pleural effusion, you can do a lateral decubitus. A lateral decubitus is where you take your patient and you turn them on their side, and you'll see the fluid go from the bases and the claustrophrenic angle region into a lateral line that'll create a lateral line lateral to whichever direction you lay them on. So if you have a left pleural effusion, if you lay that person on their left side, you will see the fluid go from consuming the claustrophrenic angle regions and the bases of the lungs. You'll see that fluid shift to give you a line along the lower left side of your body. That's a lateral decubitus. Okay, so you need to understand both of those terms. And then finally, how do we treat a pleural effusion? Well, you know fluid is in the pleural space, so you don't want to do CPT because that's not going to move the fluid to get it out. You have to physically go in and remove the fluid if it's large enough. Okay, so if it's large enough, then you need to treat it with a thoracentesis, which is a needle inserted into the pleural space and the fluid is extracted, or a chest tube. So CT here is chest tube, and you would put the chest tube also into the pleural space to allow for drainage of that fluid. So real quick, pleural effusion, a big disease process, probably lots of PowerPoints in your notes over it. But it's really not that big. It's fluid in the pleural space. That fluid is either exudative, associated with infection or inflammation diseases, or it's transudative, associated with diseases such as CHF. You'll have a confirmative diagnosis on a chest x-ray with blunted costophrenic angles. So the costophrenic angles won't appear sharp anymore. They will appear blunted. Lay the patient on their side to do a lateral decubitus, and you'll see that fluid go to gravity-dependent regions. And then finally, how do we get the fluid out? We perform a thoracentesis, or we put in a chest tube. This is the way you should be thinking about these things and talking out loud on your way home from clinicals every day. I promise you, you can gain 2 to 3, maybe even 4 hours of study time just by talking out loud in your commute time, back and forth to class, back and forth to clinicals, and you'll have a greater understanding of these disease processes. Look for more coming soon. Comments below to tell me what disease you want to see me do this same format with. This is not obviously all-inclusive. There's a whole nother patient assessment aspect of respiratory care that would complicate this list, okay? You would have to put percussion, palpation, expansion, breath sounds, physical appearance, all of those things. But I treat that in a different world. You'll learn physical assessment and tie it into certain diseases in a different world. These are the key words you need to know for pleural effusion. Let me know if this helps. Good luck, guys.